Hello, my name is Peter Jeon, and I will be speaking to you today about progressive changes in glutamate concentration in early stages of schizophrenia, a longitudinal 7 Tesla MRS study. Before I begin, I would like to state that I have no actual or potential conflict of interest in relation to this educational program. Schizophrenia is a very complex illness uh, which manifests itself as a combination of positive, negative, and or cognitive symptoms, and is believed to have glutamatergic disruptions implicated in the brain. The longitudinal trajectory of schizophrenia is also thought to have basis in progressive pathology. And not only is one part of the brain responsible or believed to be responsible for the symptoms that we observe, but most likely multiple brain hubs or a circuitry issue is responsible for the pathology that we observe. One of these brain regions that has been highly studied is the anterior cingulate cortex, which has consistently been able to show to have deficits in structure, structural, functional, or neurochemical components. Currently in the literature, there are very few longitudinal magnetic resonance spectroscopy studies looking at progressive glutamate in schizophrenia at lower fields. And to the best of our knowledge at ultra high fields, especially at 7 Tesla, there has been no work to show or investigate this progressive glutamate change in schizophrenia. So this work focused on three motivations. The first, to see if there indeed is a glutamate-mediated deficit in the anterior cingulate cortex when using a MRS technique, and if there's present in the early stages of psychosis. And the main two that we are interested in is the following: whether this deficit progressively worsens over time. For our case, the first 6 months of treatment. And lastly, if this progressive deficit exists in patients, how it compares, how exaggerated it is when compared to a cohort of healthy controls. And to do this, we recruited 21 first episode schizophrenia individuals, volunteers, who had an antipsychotic exposure of less than 14 days. So this is how we defined medication naive for our study. And for our healthy control cohorts, we had 10 volunteers. The first episode schizophrenia volunteers were scanned at 2 time points, first at baseline and the second scan at 6-month follow-up interval. And for the healthy controls, a similar interval of time was used to collect the 2 scan points. We use a 7 Tesla MRI machine, the scanner at Robarts Research Institute, and employed a magnetic resonance spectroscopy sequence, the semi-laser sequence, at a long echo time of 100 milliseconds. The main reasons for this is in a previous work, we found that this echo time was the optimal echo time to detect glutamate in the semi-laser sequence, as well at a longer echo time, the macromolecule contribution is almost gone, which makes our spectrum very easy or more reliable to see glutamate peaks. 32 averages were collected using the sequence and averaged to make a single spectrum for further analysis. And the voxel position is shown in the bottom image. It has been placed on the bilateral dorsal anterior cingulate cortex. We also collected clinical assessment scores, the PANSS 8 items, the SOFA score, DUP, which is the duration of untreated psychosis. In terms of cannabis information, we use the CAST score. For alcohol use, we use the AUDIT-C. And for nicotine, we use the Fagerstrom test for nicotine dependence. And all of these clinical assessments were used to see whether glutamate and these clinical scores had any correlation. Not only did we measure and analyze using the baseline and follow-up glutamate concentration, but we also normalized the glutamate concentration into what we call a baseline adjusted glutamate change. So each individual had slightly varying time intervals that were adjusted for use during our analysis. And to add on to our traditional statistical test, the frequentist test, we also employed a Bayesian technique, the Bayesian ANCOVA, as an alternative or supplement to our traditional test, just to make sure what we have been observing were in line, whether we were seeing evidence of absence or absence of evidence. Here we present the results. The mean duration of untreated psychosis was a little over 29 weeks for the patient group. The mean antipsychotic duration had an average of 2.95 plus or minus 3.11 days, which is much lower than the 14 days that we had as a threshold. And the time between baseline and follow-up for each group is shown. For the first episode schizophrenia group, it was just a little under 6 months in the average. And for the healthy control group, it was a little bit over 7 months in terms of the time interval. Here we present the glutamate concentration for healthy controls, shown in the blue graph, and first episode schizophrenia, shown in the red graph. And the left bars are for the baseline measurements, and the right two graph bars are for the follow-up measurements. The asterisk on the left two bars indicate statistical significant difference. So there was a significantly lower glutamate concentration in the first episode schizophrenia group compared to healthy controls at baseline scan. But this difference was not observed in the follow-up scan. As well, there was no significant difference in terms of the glutamate concentration change between the two time points for either healthy controls or first episode schizophrenia. Just as a numerical reference, the first episode schizophrenia group had a very, very small increase actually per year that we calculated during the annualized glutamate change. And for healthy controls, a very slight decrease progressively. But again, these two values were not significant. When we correlated the glutamate concentration to clinical scores, we found no significant correlation between the annualized glutamate concentration to the various clinical scores, such as duration of untreated psychosis, the SOFAs, the PANSS 8 total, and also when we looked at just the raw concentration of glutamate at baseline, we found no significant correlation with that concentration values to the same clinical scores as well. Also, we didn't find any significant correlation between daily defined dose at follow-up versus the glutamate concentration at follow-up as well. When we employed the Bayesian statistics, those tools confirmed that indeed there was no difference between the two groups in terms of the glutamate concentration, and the longitudinal change within the group also were shown to be alike. Alike meaning there was no significant change. And there was a moderate evidence with a Bayesian factor of a little over 4 for the baseline glutamate concentration being the best predictor of the follow-up glutamate concentration. So how does this all tie together? This work shows, or we were able to find evidence to show the favor of a lack of progressive glutamate change in first episode schizophrenia group when looking at time points from baseline to 6 months. And actually, interestingly, from our Bayesian statistics, we were able to show that our results indicate patients with schizophrenia already show glutamate abnormalities in the anterior cingulate cortex early in the illness. As I mentioned in the previous slide, that the baseline glutamate concentration was the best predictor of what the glutamate concentration will be like at follow-up. A recent meta-analysis by Alice Egerton noted an even split between the number of studies reporting glutamate decrease over time versus no reduction. And this is exactly why we need more work to be done in this field to see which of the two is actually correct. But interestingly, in more recent works after this meta-analysis, actually most of them found no longitudinal glutamate reduction in the anterior cingulate cortex over the time periods that they studied. And our results are more in line actually with these more recent studies. Obviously, there are some limitations of our work. First, we employed a single voxel placement. So it is quite possible that there is a progressive glutamate change, maybe just not in the anterior cingulate cortex, maybe in a different brain region. If we observed, we would observe a progressive glutamate deficit or decline, or even maybe in the anterior cingulate cortex, perhaps we didn't employ enough of a time scale. So if we had the time interval longer, if there was a longer time scale in between the scan points, perhaps we would have seen that progressive glutamate change. So these are areas that are useful for future works. Another is that the MRS glutamine is considered to reflect synaptic pool of glutamate. And our spectroscopy acquisition was optimized for quantifying glutamate, not glutamine. However, in a supplementary work, we did investigate the glutamine behavior for the same time points and the same cohorts. And we observed no significant change regardless. The values that we obtained for glutamine were not as appropriate to share in this work, but regardless, the patterns that we saw were still the same. So in conclusion, this work was able to demonstrate a longitudinal 7 Tesla spectroscopy technique on the anterior cingulate cortex, looking at glutamate, and we found stable glutamate mediated deficits that does not worsen progressively in the early stages of schizophrenia. And this work supports the possibility that perhaps the excitotoxic processes predate the first presentation of psychosis. So for example, in the clinical high-risk group, the prodromal stages, maybe that is where the excitotoxic processes are really affecting the patients. And that's where perhaps a future work can focus on looking at glutamate levels or progressive glutamate changes in prodromal stages to see how that is related to the concentrations that we observe in first episode schizophrenia. With that, I would like to acknowledge my supervisors, Drs. Jeon and Dr. Lina Palaniapen, the additional support mentioned here, and the following sources of funding. Thank you very much for taking this time to listen to this talk.